Okay, so I hope this is all set up correctly, but this is Nursing 442, End-Stage Prostate Cancer by Brad Cooper. We'll start with the elements of the patient. Age 67. He's a male, he's married, lives at home with his wife. He has 2 daughters, 2 sons. One daughter and 1 son live close by. He's on a lower socioeconomic status. He's retired with a savings account and gets Social Security. And he's basically on a fixed income. Medical diagnosis is that he's an end-stage prostate cancer after chemo and radiation therapy. And he'll have palliative treatment and then eventually end up going to hospice. So right now we're just wanting to control his pain with the morphine and nausea, vomiting with the Zofran. The adverse effects of the morphine are going to be respiratory depression, hypotension, constipation. He's a fall risk because of the use of narcotics. He's going to have the nausea because of the narcotic use. And he's also going to be at a fall risk as well. And urinary tract infections could happen as a result of the tumor getting so big that it's going to constrict the ureters, and he'll be retaining urine as a result. So nursing interventions is that he needs to be on the full cardiac monitor. You need to do vital signs every 4 hours, including respiration rates and temperature. He's at risk for falls, so you need to have all the bed rails up, the bedside table right at the bedside, and a call light button within reach. It needs to have ambulation with assistance. And again, you're going to have orders by the doctor for the nurse to give the morphine and the nausea medication. So the clinical judgments, and I know there's a little top thing here, I don't know how to get rid of that, but so the clinical judgment comparing self-care capacity with chronic illness and treatment, ambulation, and also the ADL. So you need to make sure you can walk safely without assistance or without a walking device. If so, you need to compensate him for that. Personal hygiene, take care of himself completely, can eat, can prepare his meals, aware of his own limitations, understands the need to rest when exhausted. The patient understands their medical regimen. So for the most part, the patient understands everything that's going on, understands the deficits, and understands that he needs to continue to do his activities of daily living, be able to walk on his own. He understands that he needs to keep all of these up at this point for his palliative care before his disease worsens, and where he might have to go to a nursing home or go to hospice care. So the wife takes him to all of his doctor's appointments and understand that the disease is going to eventually get so bad that he'll just have to have care to help him with the pain. So the priority patient issues for discharge planning are going to include, you need to go over the times and places the patient is going for the doctor's appointments. You need to educate, where I talked about the adverse effects of the narcotics. He needs to be educated on that. And, we already talked about that already with respiratory depression, hypotension. You need to understand that the disease can eventually cause him not to urinate, causing urinary retention. We already discussed that, so you need to give education about that. Education of the importance of taking out all the throw rugs, having lighting in the floors of the home, make sure he doesn't trip and fall, since his senses might be a little bit more inhibited with the narcotic use. You need to also make sure for the discharge planning that a home health care nurse is scheduled. Put every 3 weeks, but every week, every 1 to 3 weeks, depending on the need. It just is going to depend on the situation. Disease progresses differently for everyone. And to make sure that the medication regimen is still helping the patient. And then you need to plan where the patient's going to go discharge. So in this case, the wife is going to take him home. Home health is going to, again, check in on him, and the son and daughter will check up on him too. But safe to say that the wife is capable of taking her husband back to the house and isn't going to need any other transportation from anybody else. They're self-sufficient and able to do that. And then there's the priority, the nurse case manager. I don't know how to get rid of this. I don't know why it's there, but strategy and patient level and system level. So the priority is the patient level is to maintain a pain level between 0 out of 10 or 3 out of 10 with the morphine. Be sure that the patient's nausea and vomiting are maintained with Zofran. Need to make sure they can, again, do the ADLs. That's the priority for the patient level. Not retaining urine, patient level for the systems level. The priority is going to be that the home healthcare nurse is there every week or every 3 weeks. Son and daughter are visiting, patients keeping all the appointments, and if things have gotten worse and if the health has gotten worse, to change the level of care or to make adjustments appropriately. So the case manager strategies are going to be, as a case manager, you need to call and make sure that things haven't gotten worse. You need to talk to the doctor. You need to talk to the home health care agency to make sure that everything's still okay. Talk to children, talk to the spouse, make sure they're doing all right, make sure the patient's doing all right from them. If things are changing, you need to make sure that they're being moved to a different level of care, possibly a nursing home or hospice. So intervention for the patient level, the nursing case manager strategy. So for the patient level, you need to give support. You need to give them your number. They need to know that they can call you anytime. You need to keep in touch with them as well, with the patient and the family. You need to teach the deficits again, make sure that that's not happening with the medication. You need to collaborate with the family when problems do arrive. You need to help them problem solve them. You don't tell them what to do all the time, but help them figure it out, what's going to be best for the patient and the family. Another thing is you got to keep track. When the patient leaves the home, nobody's around him, you got to make sure he's coming home. If he's gone for 5 hours and he just went to the store, likelihood something bad happened. It could have been an exacerbation of his disease. If you're not keeping tabs on that, something seriously could go wrong with him. So it's important as a case manager that you know where he's going, know where he is, make sure the family knows where he is, and for the patient's safety. So intervention for the system level strategy with a reference. So systems level, you need to ensure that expenses aren't taking over their life. They're not putting all this money into the care, and they're not able to eat and take care of their own personal expenses. So the expenses are basically going to be from the primary care doctor, the home health agency, and eventually hospice. So you got to make sure all the appointments are being kept. If they're missed, you got to reschedule. Get records, paperwork. Make sure you're keeping tabs on the patient's medical condition. Things need to change, or that you're supplying those medical needs and those medicines, making sure that they are getting them. And you also need to make sure that they're getting the health insurance and the coverage that they need. And then with the utilization review, once the palliative care isn't working anymore, it's progressed to the point where the patient's going to pass on, you need to make sure that the hospice care is necessary. So with the palliative care, it's going to be narcotics and Zofran. That's going to be needed. The visits from the home health care is going to be needed. Doctor visits are going to be needed. This is all necessary utilization of care. I don't think that overutilization will happen if they use other things. I don't think that'll be necessary. Other forms of alternative therapies for pain management is there, but if it's going to cost them too much, then it's not going to be worth it. So quality and safety issues that we're going to have with this patient is is the medication going to control the pain? Is the antiemetic is it controlling the nausea, vomiting? How often is the um, home health care nurse actually visiting the patient? Are they going there when they're supposed to? And are they doing proper assessments on the patient? Doctor's appointments, are they going? Got to make sure those doctor appointments are of high quality. They're getting good feedback from the doctor. If there's discrepancies and the disease is getting worse, that could be a safety issue. You got to make sure the hospice care is available, make sure the quality of it as well, that you're going to have social workers available for the grieving family. And another with the safety issues, you got to make sure that he's not falling at home. And again, things aren't just getting worse. If things get worse and they don't catch it and changes aren't made, the safety of the patient could become worse, and then you got more problems on your hands, and it's going to make the life worse for the family and the patient as well. So the effectiveness at a patient level is, you as a case manager, is you know that they're going to all the appointments, that you've been effective when they know the adverse effects of all the medication, and that nothing's happening, basically nothing bad is happening. The patient pain's under control. They can do all their ADLs. They can walk fine. That's how you know that you're being effective as a case manager, because they understand all these things and nothing basically is bad happening to the patient, and the proper care is being given at the correct stage of the illness. At a systems level, the doctor's offices are having all the appointments made, that's working, that you're collaborating with all the proper medical care people, with the home health care nurses, and with the doctor, making sure that the proper level of care is being achieved within that system. And again, if it gets down to the hospice, then you need to be aware of it, and that's basically how you know you're doing well. Every level of the stage of the chronic illness is being met, and no discrepancies are happening with the families. Families not stressed out; they're being well taken care of. And these are my references for my presentation, and that is pretty much it.